Well, good afternoon. The final session before coffee or tea or whatever it is you do in the afternoons. Welcome to the Enhancing Clinical Practice and Outcome stream of the SNOMED CT Expo 2023. My name's Jane Miller and I work at SNOMED International in the collaboration and clinical engagement side, and I'm moderating this block of sessions. A reminder to everybody that we're going to take questions at the end. In this session, we've actually got a pre-recorded, but Sarah De Silvey, who's pre-recorded, she's actually online and watching us as we speak, I think, but she's there. But when we get to the end, there's a Q&A button as we go for people who are online. Please put questions in and we will talk the questions through the mic at the end after the second presentation. So I want to introduce our two speakers today. First of all is Sarah De Silvey from the University of Vermont. And our second speaker is Ebrill from Cesaro, who's at the front. So we will be they will be talking about implementing SNOMED CT to support social care. And I'm delighted to have them here because they both worked with us when we were doing our social care project. So it's great that you've come, both of you have come today. So thank you. Over to the video.
Thank you so much, Jane, and everyone at the SNOMED CT Expo. It's my honor to be here today, virtually coming to you. My apologies for not being there in person today. I'm going to be presenting on the Gravity Project and our extensive use of SNOMED CT to support social care in our work as a fire accelerator. For those who do not know, Gravity Project is a fire accelerator project that has the charter to develop the data standards to address the social determinants of health. I'm sorry. We are a collaborative that was started in 2019. Sorry, having some, this is a brief lexicon of terms that we use to ground our work. I'm not going to go too deeply into this. I had the honor of presenting at the Expo in 2021, but just basically like definitions for health equity, social determinants of health. And then when we consider social determinants of health, it's important to know that within gravity, we frame it within the literature as there being both positive forces and negative forces. And the sum total is the result of those two forces acting upon each other. So our work is to mitigate social risks and enhance protective factors toward the goal of health equity. Gravity is really honored to have many sponsors to support our work. It's hard not to say thank you for them as we do any presentation. For those of you who do not know what we do, we do operate with three work streams. There is the work stream of terminology that I have the honor of leading as the director of terminology. There is the technical work stream led by my colleague Corey Smith of the American Medical Association. And then I also help lead the pilots and testing and implementation work stream. You can see that terminology and tech really intersect and the shared product of our coded value sets, which over the course of this presentation, you'll see heavily leveraged SNOMED CT. This is well known to all of you, but the importance of data standards really are, especially in the social care ecosystem, given different histories and settings, is to establish a shared understanding of critical concepts across the ecosystem in the name of health equity, to allow for data visibility, a critical aspect of data justice, and to create common methods for exchanging information within communities across clinical and social care settings to allow for analysis and upstream structural interventions. These are the core Gravity Project use cases: documenting care, sharing care, and then gathering and aggregating social care for uses beyond the point of care for the structural interventions. We do operate under 6 critical principles: the principles of improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. Each of these principles can be found on our very comprehensive Confluence, which is easily accessible by HL7 Confluence. I'm now going to go into the meat of the presentation about how the terminology workstream leverages SNOMED CT to address social care. One really important thing before we go too far into it is what we say at Gravity is, although we might identify social risks in clinical settings, we solve them within communities. So Gravity's approach to terminology development includes the community perspective by design. In the name of semantic consistency, all built within Gravity terminology ensures shared definitions with social care and social services when possible. This ensures that we leverage the wisdom of social care entities and that we allow for mapping from clinical terminologies to long-standing social care documentation and reporting requirements to reduce burden and ensure semantic consistency across our settings. When we build our terminology, we balance many different types of knowledge of clinical informatics, knowledge of terminology, knowledge in subject matter expertise, and knowledge of the community. This creates our final consensus evidence-based data sets that are pragmatic and fit for use and sensitive to the evidence on both health outcomes and impactful interventions. Also, while we develop our data standards, it's important to know the activities that we lean into, developing terminology to support screening via standardized instruments, developing terminology to support assessment, including assessment of social risks, and leaning into assessment of social and environmental context, assessment of patient-centered goals and documentation of them, and then broad intervention and treatment terminology, the activities that are completed by both clinical and social care roles across the community of care. This is really critical because of the diverse nature of care settings. So we know from our practice that with sometimes social services are co-embedded with clinical services, or sometimes they're not, but we need to make sure that we have the programs and terms that are supporting people toward health equity in social care services, regardless of the setting. When we think about psychometrics, I mentioned this earlier, this is partly where we see SNOMED CT really leaning in to help with documenting what we call the subdomains or the dimensions of insecurity. You'll see this as we go forward. So there are a few core elements of any finance-driven insecurity: worry, stability, quantity, quality, and cultural acceptability. Subdividing each of these can be complex in ICD-10 terminologies, but is really capable within SNOMED CT, and you'll see that playing out over the course of the next slides. You can see even very specifically within housing, as we break down housing insecurity as a metatype into housing instability, homelessness, and inadequate housing, as you can see on the last columns. The terminology comes to life when you look at this example of food insecurity. It's the encoding of those screening instruments, encoding of diagnosis. You can see that food insecurity SNOMED CT term, my first, submitted in 2019. Food insecurity goals, both meta goals of food security and halfway goals, such as food intake quantity is adequate. And then all of the robust intervention terms I mentioned that from a US ecosystem and international ecosystem are really critical for advancing social care goals and health equity. Here you can see those subdomains of SNOMED, of the dimensions of the domains that I mentioned. So SNOMED CT are really helpful for driving down and drilling down on social risk dimensions. The really cool thing about subdomains and their dimensions is they're often aligned with different interventions, which are also capable of being diagnosed, of being documented in SNOMED CT, and also really wise to use when we consider evaluation. So you can see the meta term of ICD-10-CM, transportation insecurity. When we look through the SNOMED CT lens, you're able to break it down into different subtypes. Transportation insecurity due to no access to vehicle or inability to access healthcare, or due to unaffordable transportation. And these are aligned with possible SNOMED CT interventions: referral to automobile share program, or referral to non-emergency medical transportation program, or provision of public transportation voucher. Again, SNOMED CT being really the critical terminology for those more sensitive and specific diagnoses types and the interventions that are built to align with them. The intervention terminology is really embedded with SNOMED CT. It's the core terminology in all of Gravity intervention terms. It really establishes the activities and services of social care, again, across the clinical and community setting, and it's structured around all the ongoing activities of patient-centered care coordination. You can see this really defined syntax of these core activities: adjustment, assistance, coordination, counseling, education. evaluation, provision, and referral that are then commonly defined and commonly wrapped in syntax around all core social care programs we have within the Gravity sets. This is going to play out over the course of the next few slides here. I really wanted to demonstrate to you all what this looks like in practice. So with food insecurity, this becomes very specific provision terms that, again, have critical food-related interventions. It then also plays out in referral terms. We imagine a couple different types of referrals within SNOMED, within Gravity. Refer for further assessment, which is when I refer to an entity that can pick up the baton and carry it forward, whether it be social workers or charitable organizations or case or care managers. But then we also imagine refers to provision. In this set, it's almost all US programs, so not international. But in the prior set, there were a lot of international programs, international roles of note and international terms. But from a US perspective, you can see almost like all of the core food intervention programs and social service food programs are represented here. And this correlates then against all of the other 19 domains we've addressed for housing, transportation, material hardship, health literacy, et cetera. Again, the refer to provision is there for specific documentation. We also build general coordination terms, again, thinking of that activity syntax, so you can document specific coordination of resources to address food insecurity. You also can have general coordination of care team terms or coordination of care plan and other care planning activities that we again are really critical for social care documentation. And then lastly, there's terms for specific coordination, specific assistance with application for those programs I mentioned, and evaluation of programs. We want to invite you all to join with Gravity. We have 3 different work streams and meetings, and we hope you see them. We see you at them in the future. Thank you so much, and I look forward to joining you on the panel.
I'm Kate Ebrill, so I'm from CSIRO, which is Australia's National Science Agency. We've been really closely watching the Gravity project in Australia, but we've come from a really different perspective around what we've been looking at, around what our requirements are within Australia. And obviously, I know all in the room are very familiar with this around, what goes into your health, that it's not just around, the health and biomedical, but it's the social economic factors, health behaviours and physical environment. When you look at social determinants of health in the scope, it's huge. It's like this massive elephant, and how do we start to bite it off? And I do have to firstly, before I go into a whole lot more detail, acknowledge that I'm actually using slides prepared by Heather Leslie, who works with us very closely in Australia around the work that we're doing around where we started 4 years ago, which was actually looking at a primary care data model. What's that core common data that we require in primary care? If that information's in that electronic health record, that information can be reused multiple times across multiple use cases, and really trying to support that single provision of data, multiple use by the clinicians. And yes, I am losing my voice. We've really come from understanding, first of all, what's the data needs for our clinicians across healthcare. What do they need? What's the information they need to manage their patient, share that information to the next person in the care chain, and how that data might be able to be reused at a national level. So we started building up that common data model. We are now running an accelerator in Australia called Sparked as well, which is looking at building AU CDI, kind of think US CDI, and building out AU Core Fire IG. And part of what we're trying to do that is define that data model, but in starting with the clinical data, but then starting to move to what we need from a social care perspective, social determinants of health. So when we kicked off our work, we started working with the Royal Australian College of General Practice and the National Aboriginal Community Controlled Health Organisations in Australia. And they were looking at how do they support in their Aboriginal and Torres Strait Islander health assessments, which are an annual item of care? How do they actually support recording that information within the clinical record, that information being able to pre-populate a questionnaire? We're looking at 5 questionnaires. And as part of that, we had to start to say, well, how do we represent social and emotional wellbeing? It's very important, in terms of Aboriginal and Torres Strait Islander people. Social emotional wellbeing is the social, emotional, spiritual, and cultural wellbeing of the person. It's that holistic health viewpoint. And it's similar to something that was put up earlier. We have to also not focus on the problems, but also it's really important, and where the strong focus is looking at strength-based behaviours. So how do we actually, in our record, not always be doing screening tools and focusing on the negative, but actually starting to record this information in a culturally appropriate way, record it in a clinically relevant way, and make sure that we're also focusing on strength-based behaviours. And Alana, I can see you nodding, and I know speaking to your colleagues at High in Canada, you've got similar programs, similar objectives are looking at how do we represent culturally appropriate information for our First Nations populations. So, when we look at social determinants of health and everything, which is fantastic, that's been included in the Gravity Project, we had to look at what's actually recorded in our EHRs and how should that information be recorded actually in the EHR. We don't have a standard set of assessment tools that we use within Australia. It's more information that's recorded in ad hoc in EHR, maybe then including some health checks. But how do we start to record in EHR information about food and nutrition? So we just don't want to know about food insecurity, we want to know about strength-based behaviours and other behaviours around food. How do we look at housing situations and dwellings and, the complexity around is someone housing insecure or not, but also important is how many people live in the house. For us within our First Nations population, is there a fridge in the house? With otitis media being a very large problem, we need to know, is there a fridge in the house so that antibiotics can be stored? So it's what all that information that's actually truly required to support care. And then obviously importantly, when we look at things like financial situation, social networks. So, not all of the information that's kind of defined within Gravity, which is really valuable, is actually kind of recorded in that EHR in that way. So how do we start to say, well, what's the kind of information that could be recorded within the EHR, structured, coded in SNOMED, that might then trigger a screening tool to be used, or might trigger off to some of these more formalised assessments? So Heather, if anyone knows Heather well, she's very active and an open expert and does a lot of work with mind maps, which is brilliant to start to look at this. And I'll just flick on to the next one. So if we start to look at, social emotional wellbeing and how do we start to break that down and define that data model and then start to find those terminology elements to support it. So I'm going to quickly go through these to really talk about where we're wanting to go, which is work with our Aboriginal community controlled health organisations, other organisations within Australia. And as we're building out AUCDI, always keep sight of what's happening with Gravity, leverage Gravity, but how do we also supplement that? We can look at how the content should be structured within the EHR to support that broader primary care, social care. How do we identify that so that it might be information that's more relevant or appropriate to be included within that EHR to send on to the next person in the care chain beyond just when I'm actually doing a screening tool? And how do we really look at the social and emotional wellbeing aspects of what we're doing as well? So we're taking baby steps. We're leveraging what's out there. It's what we do. Reuse, that's a whole benefit of standards. Reuse and continue to improve. And again, like coming from that, if we can start to have that information identified in a way that makes sense to be recorded by the clinician in the record, then that data could automatically start to pre-populate assessment forms, pre-populate questionnaires, reduce that burden on the clinicians. One of the really important things that we found, and I really like the work in Gravity around the interventions and the procedures, what we hear from an implementation point of view, that it's and to get this implemented is when we've spoken to clinicians and we've asked, around health checks and this, what's the barrier to doing that properly? One of the key barriers that we hear is that the clinician, it's delving into really sensitive personal information. And if the clinician or care worker can't identify what the intervention is and where to go for that intervention, it becomes this process where they're just asking for personal information, ticking a box, getting a payment and leaving the consult and moving on. So I think that really important, what I like about Gravity is closing that loop around recording that information, but also importantly identifying, and where we see in Australia what's really important is how does this feed into provider directories and service directories and the rest of it? So you identify that there's housing insecure or food insecurity, but you can also identify immediately what are those services, what's that intervention, but importantly, where do I go? How do I connect that person immediately with that intervention? Because if we're truly actually trying to provide a value service for the consumer, most importantly, but also for the clinical care team, the social care team, we need to be able to support those referrals on. So we see that loop of how that all comes together. And part of it is also looking at how do you develop tools that are patient-friendly, consumer-friendly. So for some of these things, how do we create tools that can be consumer-entered using the right terminology to support that can actually start to use some of these screening tools in the waiting rooms, rather than always be that kind of and we feel it may be actually in some sensitive situations more culturally appropriate, easier on the consumer, on the individual, if we can think about how to build these tools. So, what type of data? We want to have the data that's identified using SNOMED to trigger, as I say, the assessments and decision supports. We want to be able to auto-populate. We want to be, fundamentally, we're about record once using SNOMED, be able to reuse that. And I think really importantly, differentiate between what's the valuable information that we record in SNOMED within a clinical record that means something to the clinician and the consumer, versus what's just that information that might be needed for reporting. So we're all about how record once, we keep saying again, record once and then reuse and be able to aggregate that up for national reporting. So we kind of see that what we're trying to do is be complementary to the work with Gravity. I expect as we start to move down, using more screening tools in Australia, we'll absolutely be leveraging and using Gravity, but we're really trying to look at that whole spectrum of data recording within the systems. Thank you.
So thank you, Kate, and thank you, Sarah. Sarah is online. Can we get her photo, her live up there? I don't know if we can, but Sarah, we know you're there. Can you speak to me? Nope. Meanwhile, have you got any questions? Yeah. I mean, we grab the mic. I mean, we want to hear from you because I don't know if you saw the other day, but Ian put up in a session, I can't remember which day of the week it was, but anyway, we want to put together a social care group to help us with this. So please come to me and give me your name if you're interested. We want to try and help to move this forward, but based on requirements. Over to you.
Thank you. Jay Lyle with supporting the VA. This is more of a SNOMED question than a social determinants question, but I notice a lot of the issues tend to be not findings of disorders, but absences of positive effects. And how are we modeling those? Are those findings?
Through to.
There you go. Sorry, guys. Do you want to answer it? You've been working in that area more than me, but. So we're early on at the international level in adding content in relation to social care. There's been some requirements work done at the international level looking at that. And we have also been involved in the Gravity. So together with the US, with John Snyder, have been meeting with the Gravity team. So the content's been added. A lot of the content at the moment is findings and procedures that are going in. So as we go further, we may need to look at going to other hierarchies, but predominantly at the moment it's findings and procedures that we're adding. But it's as the use case requirements come in, then we can look at what content we need.
Thank you. Do we have anything else?
I know that your colleague was something
similar
in Canada.
Hang on.
Sorry.
No, go ahead.
No, yes. I'm supporting it, but I'm not really anything about it. But it's nice to see that everybody's bringing the gravity.
Everybody's bringing the gravity piece together, and we're all going to that shared goal. And I like what Jane said, bring people together if you're willing to work together, because we're all trying to do the same thing, really. So it's wonderful to see. Thanks.
Hi, Kate. I'm intrigued by your presentation, and I think I heard you talk about the clinician perhaps completing an assessment, but also the patient completing questions. And I'm wondering about that. I'm intrigued and would love to know more. And perhaps if you're going to do some pilots or have done pilots,
Yeah,
and how we could work together on.
Yeah, absolutely. So with the Aboriginal and Torres Strait Islander Health Check, it's an annual item of care that covers across 5 ranges from birth through to 75 plus. It's quite an extensive questionnaire, and a lot of that data should actually be, if it's been recorded in the record, be able to be pre-populated by the clinician. And the aim is that consultation session is really that check-in point, having more of a conversation and understanding what those interventions should be and what those goals are. But because there's a lot of data re-entry, it becomes a clinician typing, no real engagement with the individual and no ability to kind of reuse that information. So we're using 5 questionnaires. We're using an approach around smart apps to do that so that they can actually be completed by multiple different providers. One of the things that we've been discussing with the Aboriginal and community controlled health organisations is particularly what are some of those aspects that if we actually gave it to the individual to pre-complete or complete in the waiting room, so how that might add value. And some of those particular ones around that are teenage boys and sexual health and sexual activity. Maybe that might be easier for someone in the waiting room or pre to actually start doing that than having to face the older female Aboriginal care worker where you're not really wanting to answer those questions. So it's something that we want to actually continue to work with the college and nurture around looking in those pilot stages around how we do that. So we're not saying it would necessarily be everyone, but who are those groups? Similarly, mothers with lots of kids, you know, it's too hard to be in a long consult. How do you do that? And we kind of feel that going down the approach of using Smart on Fire, being able to like send questionnaires out in advance, have bound to the value sets, that we're now in this world of technology where we can support that and still bring that information back, be SNOMED coded and bring it back together.
Thank you. Thank you for that question. Is there anyone else? Have we got, it says Sarah disappeared and we haven't got Sarah.
Right here. Can you hear
Oh,
me?
good. Sarah, is there anything you want to add?
Besides my deep thanks for the team at SNOMED CT, other than that, I do want to make sure to thank you and John and Kathy and Susie and all the collaborators at SNOMED CT that have helped build the really robust terminology that we have now in the social care space. So it's hard to give a session on this without nodding to the capacity of SNOMED CT and the wisdom of the team as we all work together on this. And it's wonderful to see it referenced in other entities and other states. And I am glad someone mentioned we all are trying to do the same thing. And there are very common best practices in this space. And I'm glad we can share the evidence and science and learning around that.
Thank you. Thank you. All right. Okay, well, if there's nothing else, I'd like to thank the two of you again, very much indeed. And I won't stop you going for your cups of tea, coffee, buns, whatever it is. Thank you.
Thank you, Jane.